Thank you, Peter. It's an honor to be here today, and I think Radha's done an amazing job with these conferences. You know, we're used to just coming here and reading our PowerPoint slides, and usually, you know, you're not nervous about your talks or anything, but here you actually have to tell a story and try to engage the crowd, and, you know, it's much more involved, and so all the speakers will probably tell you that we put a lot of effort into that, and, you know, we're thinking about it constantly. So, this is Alexander Fleming. He was a famous British microbiologist, physician, and researcher. In the early 1900s, he was in the army, and he noticed that a large proportion of veterans were dying from infections from their wounds. He then took on a research post in the UK, and eventually, in his lab, was studying bacteria and how to defeat bacteria. And one day, while he was studying influenza, he looked at one of his bowls where he was growing Staphylococcus bacteria. And he wasn't known for his cleanliness or tidiness. And what had happened is that there was some mold growing within these bowls of Staphylococcus. And most of us would just throw this away and, you know, realize that it was a contaminant. But he looked at it carefully, and he realized that the bacteria around the mold were dying, and that there were no bacteria that were growing around the mold. And from this, he basically came to the discovery of penicillin, one of the greatest discoveries in modern medicine. And it happened by chance, really. This saved hundreds of thousands, millions, and billions of lives. And all of us in our clinical practices are researchers. We're all scientists. And we never know when that next patient who walks in the door is going to give us a clue or a hint, or is perhaps we're going to see an observation or a clinical sign that will lead to the next discovery or to the next innovation in our field. And today I'm going to talk to you about how we can leverage our busy clinical practices where we're just seeing patients over and over again, but how we can think about these patients and formulate hypotheses, test these hypotheses, and then dig deeper in this research and how we can help try to innovate within our field. And for me, the area that I'm focused on is retinal detachment repair. You know, Peter has talked about how I trained with him, and early in my clinical practice when I was a resident at PGY2, I remember seeing a patient like this who had retinal detachment and who presented, and, you know, this patient came in and she was a one-eyed patient and now was losing vision in her only eye, and I saw this patient and I realized that it was a retinal detachment, and, you know, took the patient to my staff and thought that the patient required surgery. But I was quite amazed that you could treat this without going to the operating room by just injecting a gas bubble in the eye. And you know, Peter and I worked together at that time, and over a few months I had treated 5 or 6 retinal detachments, and I was amazed by this procedure. And eventually I went to other hospital sites, and now this has become the predominant way of fixing retinal detachments in Toronto. I would say before that we were doing buckles and vitrectomies on most patients. And this is the patient one day after a pneumatic retinopexy, where you can see that the retina has been completely reattached. And this is 2 weeks later here, where you can see a successful retinal reattachment. So the first step is, within our practices, we need to recognize a problem and formulate a hypothesis. And for me, the problem was that although we were successful at reattaching the retina, we would tell our patient, hey, you know, Mr. Smith, you're doing great. Your retina is completely reattached and everything went perfect, and I'll see you in 6 months. But they're like, wait a second, what are you talking about? I can't see at all. I have distortion in my vision. I see when I look at you, your head is miniature and the rest of your body is large. You know, you look farther, you know, things look farther away with one eye compared to the other. And so even though the patient had a vision of 20/25 or 20/30, they weren't seeing very well from their perspective because of the metamorphopsia and the distortion. And this to me was a concern. And the first thing I looked at was, okay, how are we treating retinal detachments? Are we doing it the right way in Toronto? And should we be doing something different? If you looked at Bascom Palmer or the Mass Eye and Ear, they're doing vitrectomies or scleral buckles or combination, very elaborate surgeries for patients with routine retinal detachments. Are their outcomes better than ours? And if, these slides here basically show that the predominant way of treating patients throughout the world with pseudophakic and even phakic retinal detachments is vitrectomy surgery now. So the first step was, okay, we have a captive audience here. In Toronto and in Canada, we're very lucky because as subspecialists, we get a large proportion of the patients concentrated in a few locations. So for retinal detachments, there's 3 centers in Toronto, whereas if you go to the US, you'll have 1 or 2 detachments in multiple offices all across that state, for example. So we have an ability in Canada where, because things are so concentrated, we can do clinical trials relatively easily because we can recruit patients faster. And so we conducted the PIVOT trial at St. Michael's where we randomized patients to vitrectomy versus pneumatic retinopexy. The simple question was, which one was better in terms of the patient's functional outcomes? Where did patients do better? And we all know that there's different advantages with pneumatics. You don't have to go to the operating room. With vitrectomy surgery, it utilizes the OR. And so there's a number of different factors that may affect the surgeon's decision, including their training and experience. But we wanted to just know from the patient's perspective what was better. And the results showed that pneumatic retinopexy was better than vitrectomy at every time point, at 3 months, at 6 months, and even at 1 year. And you see the uptick in the vision with the vitrectomy group was because between 6 months and a year, we took out all the cataracts that developed in the vitrectomy group. And even considering that fact, that we were aggressive at removing cataracts from vitrectomy patients, patients who had pneumatic retinopexy still did better. If we look at the anatomical success rates, it wasn't that bad. The primary success rate was 81% with pneumatic retinopexy and 93% with vitrectomy. Now, we expected that the primary success rate would be higher, but that difference was only 12%, which means if you were a vitrectomy surgeon primarily, you would need to treat 8 patients in order to prevent 1 patient from going to the OR. So we felt that the success rates with pneumatic retinopexy were high enough. And what we noticed was that if patients failed the pneumatic and then went on to have vitrectomy, that they didn't lose anything. They had the same visual outcome had they gone to vitrectomy from the beginning. And that was very important for us as well. Let's look at it from the patient's perspective, the quality of life. Pneumatic retinopexy did better at 3 months and 6 months, but there was no significant difference at 1 year between the two. So now we've recognized the problem, which was the outcomes in our patients. We tested a hypothesis with this clinical trial. But we can't stop there. The next step is to dig deeper. Once you have an initial set of data, you want to look very carefully. And, just like Alexander Fleming, who looked at this Petri dish that he was about to throw away, and from that came one of the greatest discoveries in modern medicine, whenever you have a set of data, you never know what it's going to show. And what was interesting to us was this was the first clinical trial where we looked at distortion. So we measured vertical and horizontal distortion using a test that objectively quantified this. And what we found was that vertical distortion was significantly less with pneumatic compared to vitrectomy. And this was mind-blowing because, how all treatments relatively work the same in terms of reattaching the retina and putting it back in place. So why would one procedure be better in terms of another from a distortion perspective? To me, the first thing I thought about was that, the cells that are reattaching must be reattaching in a different way with one procedure compared to the other. And so the first thing we did is looked at the OCT. So now we look at the OCT and we're looking at the outer lines in the OCT. And here you can see there's 4 important lines. There's the retinal pigment epithelium. Then there's the interdigitation zone. That's where the photoreceptors connect to the retinal pigment epithelium. And then finally, we have the ellipsoid zone, which is the junction of the inner segment and the outer segment. And finally, we have the external limiting membrane. So if we look at these 4 layers carefully and compare the 2 groups within our randomized trial, we'll know how the photoreceptors have aligned back to where they were. And, that particular patient there shows a disruption, significant disruption of the interdigitation zone following vitrectomy. And it's so turned out that there was statistically significantly higher disruption of all of these layers with vitrectomy compared to pneumatic retinopexy. So now we know that there is a difference in the integrity of how a retina reattaches with one procedure versus another. But we still don't understand exactly why is that happening. So we were at a conference in Europe presenting some of these results, and there was another talk on a completely different topic about autofluorescence and how you could see if retinal vessels had displaced, how you could tell on autofluorescence. And I thought this was amazing, that you can tell from this patient here who had a vitrectomy surgery that this, what we call a retinal vessel printing, is where the retinal vessel was before, and this is where it is now. And we realized that perhaps this was the clue that we needed. Perhaps in pneumatic retinopexy, the retina was going back in place exactly where it was before, or closer to where it was before, and perhaps in vitrectomy, this wasn't occurring. And so we conducted a study. I'm going to show you some of the patients from this study where we compared autofluorescence between these two groups. The patient on your left is a patient who had vitrectomy surgery. And you can see that their vision is 20/25, their retina is attached. The patient on the right had pneumatic retinopexy. Their vision was 20/20, and again, their retina is completely attached. So on the surface, these two patients look exactly the same. They've both done very well from our perspective. But the patient on the right, let's look at him more carefully. His vision was 20/25, but he had an M-chart score, which is our distortion score of 0.4, horizontally and vertically, and the anisoconia score of 24. In other words, there was significant image size disparity and distortion, and this patient would be the one wearing the patch on their eye. If we look at the autofluorescence, you can see here that there's been a rotation of this vessel here down and a significant inferior displacement of other vessels. So even though the visual acuity was preserved, the retina we did not have a high quality retinal reattachment. If we look at the OCT, we also saw those same abnormalities of the interdigitation zone, signifying to us that the retina did not reattach as well as it may have been able to. Now let's look at the patient who had the pneumatic, who is 20/20, has no distortion and no anisoconia. And this is just one example, but the majority of the patients in the pneumatic group had this. Here you can see no retinal vessel printings. You can see that the retina has gone back in place to where it was before. And if we look at the OCT, there's no disruption in the outer retina. So when you put this all together, we then analyzed these results and found that the rate of displacement in vitrectomy surgery is in the range of 40 to 50%. If you look at pneumatic retinopexy, the displacement rate is 7%. So we have now discovered that for the first time, that there's a difference in not only getting the retina on and attached and the vision, but a difference in the integrity of how the retina reattaches. And if we look at this pyramid of success here, this is where we used to focus all the time before, telling our patients that they've done great. But now we're looking at the microstructural integrity with OCT and the autofluorescence to look at the alignment of the retina, and this should allow us to improve our functional results for patients. So we've recognized the problem, we've tested a hypothesis, we've dug deeper and analyzed these results carefully. What's the next step? Well, now you have to apply these results. Of course, everyone in the world is not going to start doing pneumatic retinopexy for various reasons. But here we have a model of a way to reattach the retina without displacement. How can we apply that to vitrectomy surgery? In vitrectomy surgery, we're removing the vitreous from the eye. But do we really need to put a full gas bubble in the eye? Do we need to drain all of the fluid? What if we did the vitrectomy and then used the principles of pneumatic retinopexy to improve outcomes in vitrectomy surgery? And this is where we're working with next. We're working with chemical engineers. Arun Sundaram is here. Sorry, Arun is here from the Department of Chemical Engineering, and we're now working with him to figure out exactly, using theoretical models and experimental models, on how we can try to minimize the impact of this displacement and this distortion on patients. And Arun has created these amazing curves that show how the pressure on the retina is different in different circumstances with different sizes of bubbles in the eye. Now, we don't think it's just related to the size of the bubble. It also has to do with the amount of fluid that's left under the retina, which there always is some fluid, which allows the retina to be mobile, and also a number of other factors, such as how the patient positions, etc. So, in summary, I found this area of interest that I was passionate about, and from there, I was able to ask certain questions, formulate hypotheses, do clinical studies, and then dig deeper, and now try to apply that to my field. And I'm hoping that all of you, as busy clinicians at the University of Toronto and in Ontario and around Canada, can look at your practice and think about something that you see day in and day out that maybe you've stopped thinking about in a deeper way, and maybe identify a specific question or a hypothesis that you can test through your busy clinical practice and help to advance and innovate in your field as well. Thank you.